So, hi, Joe. For those of you who don't know me, my name is Anna. Hi, guys. I've been a speech pathologist here at Christ for 15 years now. And a lot of that has been in the area of head and neck cancer. So I work very closely with Dr. Tucker from ENT, who you all have now met probably a couple of times. Some of his partners as well, and then Dr. Valley from radiation oncology and Dr. Hamad from oncology. That's sort of the basis of the head and neck team here. And so the purpose of this today, because you guys are seeing more and more of them, we're getting another surgeon as well, so the volumes are probably going to increase a bit, is figuring out the difference between the total laryngectomy patient and the standard head and neck cancer patient, if that's actually a thing that exists. But your role as nurses straight out of the OR becomes hugely important for us and overall patient outcomes. So we just want to make sure everybody's got a really good picture of what they are actually dealing with anatomically, as well as how to help us care for these patients. I'm going to go over my brief overview. It's very quick, but in the past, we've opened this up to question and answer, which actually feels pretty beneficial. So the first thing to know is the difference between the two, right? So when we're called on for both sides of these patients, the head and neck cancer and the total laryngectomy patients, the speech pathologist's goal is to improve pulmonary function, communication, and swallowing in both sides of this incredibly complex patient population, okay? In patients with a total laryngectomy, their anatomical reconstruction, and I'm going to pass two of these around so you can see. On the right side here, you're going to see normal human anatomy. Obviously, this person has been cut in half, facing this way. So you've got your base of tongue, you've got your epiglottis, you've got your larynx and your trachea and your esophagus. In surgery, and you'll be able to see the operative site here edged out. What Dr. Tucker and his partners do, mostly him because he's obviously the main reconstructive surgeon that they have on their team right now. He removes the entire larynx, which includes the hyoid bone, thyroid, epiglottis, and typically the first two tracheal rings. And what happens is the trachea is then sewn to the outside of the neck. Okay, so if you take a look, you can start passing that around. Go ahead. As a result, there is no more connection between the airway and the mouth and nose. So that means two things. The patient physically cannot aspirate anymore, right? Great. That's one of the problems we try to solve, because typically these patients will come in with pretty significant swallowing trouble and voicing issues, typically as a chronic trach patient. So now you've removed the entire larynx, sewn the trachea to the outside of the neck. I'm just going to pull this out of trach tom for a sec. Creating a permanent tracheostoma, okay? You'll see those in those pictures, and I have another one here I can pass around too, so you guys can maximize that. All right, so in a total laryngectomy, patients typically are not going to aspirate. There is a level of dysphagia that occurs with the reconstruction, but that's all very manageable, usually involves some reflux. In a head and neck cancer patient who is a chronic trach, you're going to have a severely elevated risk of aspiration. You're probably going to have voicing problems, sometimes a dysfunctional larynx completely. So the difference is total laryngectomy, can't aspirate, there's no connection. In a chronic head and neck patient, a lot of times they are trach dependent, and they usually, because a lot of these areas have either been radiated or are non-functional because of a mass growing in these areas, you're going to find significant dysphagia and voicing issues, okay? So when you look for communication purposes, okay, so you've got, this is trach tom, okay? You've got a patient with head and neck cancer who comes to you with a trach tube in place, right? To help the patient talk, we use what's called a Passimier valve, not a cap, a Passimier valve. The capping comes from you guys and the respiratory therapists. But the cap, or the Passimier valve, is then just placed on the outside of the trach tube what it does is the patient is still able to breathe in through their neck. The little diaphragm inside closes, forcing air up then through the glottic space and the vocal cords, creating voice, okay? In a laryngectomy patient, and if you can want to use that as reference, that's not possible, right? Because this whole area has been removed, right? So in this wall, so imagine if you want to look at those, there is now no connection, right? The larynx is gone. So in this little space here, Dr. Tucker would put in what's called a TEP, or a tracheoesophageal voice prosthesis, okay? Here, actually, could you pass these around to, I'll keep one, to whoever wants one. And that is a tiny, tiny little clear circular piece that you can see inside the patient's stoma, okay? And I have one here to pass around as well. Without the tail on it, this is what you see, okay? It's real big and noticeable, right? The TEP sits in the party wall right about here. So in a total laryngectomy, remember, this is the connection now, right? This is a permanent tracheostoma, and he will put in a voice prosthesis in some of the patients so that when they are well healed, the patient can cover their stoma, right, their only airway, because it's not through their mouth and nose anymore. That redirects the air through this tiny little prosthesis, and it vibrates the walls of their esophagus. That's where you get this voice. It's a new vibratory mechanism in the absence of a larynx. So it's important to know, though, because, and you can pass that around too, because it's so small and easy to lose.
They just sew it in there?
No, he creates like a little piercing. It's like a little puncture. And then the two flanges on the other sides hold it in place. ENT and the speech pathologists manage that little thing.
Is that something new? I never heard.
No, both guys here have them. Both guys on the units have them right now. And we try to encourage him to put them in every operation, just because it makes our jobs a lot easier on the other side. So, okay. When they come out of the OR in an ideal world,
yes. How do we know? Do we get that report or whatever if they have those?
It should be in the operative report, yeah, or else you can just ask us. We'll know if he put one or not. Okay. That's one of my first questions to him. Okay. So that literally is like going for a day up procedure and a piercing. So in a very ideal world, which is neither patient up here right now, they are going to come out of the OR with either, well, I'll go both scenarios. Either your standard Shiley trach tube, it should be probably a 6 or an 8, okay? More perfect scenario would be what's called a laryngectomy tube. This is what they look like. They are soft, bendable, elastic, and way more comfortable for breathing. Because now think about this. This is the patient's only airway, right? They no longer breathe through their mouth and nose. So now you've got this nice, comfortable, easily removable thing, or a rigid trach tube with an inner cannula. It's like breathing through a straw, right? So we try to move to get patients into the laryngectomy straight out of the OR or within post-op day 1 to 2. If they're a flap patient, which a lot of his are, it's a week, but that's an argument I'm having right now. So what people tend to worry about with these patients, and what I usually get the wide eyes, especially with the newer nurses who haven't seen this a lot, is when I come in and I say, okay, I'm just going to take that tube out of their neck and either replace it with something else or see how things look. Because as we're all trained, if somebody has an alternative airway or a tube in their neck, you do not remove it or touch it, right? That's what we were all taught. But with a permanent tracheostoma, such as a total laryngectomy has, that tube has to come in and out because it needs to be clean. We ask that nursing help us with keeping it clean because, again, it's the patient's only airway. So if that's clogged with secretions, the patient is not going to be able to breathe. On top of that, we really like the air to be filtered and humidified, and that takes away the need for oxygen, right? Yay, no more trach collars. And that's what this little thing is. It's called an HME filter, heat moisture exchange. It also, when the patient's ready to talk, functions as a button to help occlude their airway, forcing the breath through their prosthesis. It's all in all a very good little device. But it's filtered, it's porous, and it's humidified. So if a straightforward laryngectomy patient can switch into a tube and an HME post-op day 1, takes care of the need for any supplemental oxygen. And it helps with mobility and independent use because we try to incorporate the patient education, their families right away in self-managing this. They're gonna have to anyways for the rest of their lives, right? So that sort of takes care of the whole front page of this. Where we need help from you guys and where we'll start taking questions is these filters are to be changed once a day, okay, by anyone at this point. Anybody who knows what they are, let's be serious. When the patients come out of an OR, for those of you familiar, you'll remember the white suitcase that comes with them. It's the post-op kit that we give to the patients. That in that kit is 30-day supply of these filters. General Stores does not supply them. It's the OR and or myself or the speech pathology department for various reasons. But in there is a 30-day supply of these filters. They are to be changed once a day, or if really, really mucked up and just unsalvageable. They can be wiped off. We tend to say, please don't rinse them and air dry them. And then keeping the tube clean so that people can breathe easier. It's very easy to place the filter on the tube. It just pops in and pops out. There is no locking mechanism. That's designed so that if the patient needs to, they can take it off very easily and have a big cough, catch it at their neck, and put it back on. So yeah, if you want to pass it around, try to just pop it in and out. Don't be scared to pull the tube out, okay? Especially if somebody's clogged. That's the big thing people are saying is that, oh, I don't want to touch it. Please do. It has to be clean. It has to be maintained so that people can maintain their airways nicely. If for any reason you're having trouble getting it back in, which you shouldn't with a little lube, just call one of us. We'll come right up and help you with it. No problem. Other than that, I kind of want to open it up to questions you guys have about it because I know that's in the moment where things come up. Does all that make sense? And as to how they're different from a regular trach patient and how...
We clean it the same way as a trach?
You can either suction it if it's a quick and easy, but since there's no inner cannula, our typical recommendation is to take the tube out completely because the stoma will not close. It's permanent, right? Run it under the sink with one of the trach care brushes. Get it sparkling clean and then reinsert it. If you keep it in situ, it's just a little bit less aggressive of a clean and you can still get some nice stubborn mucus in there.
So when is it appropriate to transition our patients from the trach to the...
So we do that part.
Oh, okay.
Yeah, we do that part. The speech pathologists or sometimes Dr. Tucker or whoever's following up will take a look and say, let's just pop the Larry tube in. So you don't have to worry about that transition.
Okay.
We usually do that. Like I said, typical rule is after a flap, like a radial forearm free flap or the 5 flaps, he likes to wait a week before we're even allowed to unsuture the trach.
Okay.
Again, that's in debate.
Because when we have a fresh trach, we would never want that, like, that's why we have the obturator in the room and all that stuff, and we do worry that they would close, but fresh laryngectomy is not the same way at all. It cannot close. It's like if you ever had a patient pull their trach out on you and you're like, where is...
Yeah, where's the hole?
We've had
so
a psych patient
it's his whole
before.
trachea that is sutured then to the outside of his neck, right?
Okay.
So there's
No way it can close back.
they can shrink with pre-radiated patients, but not in the time it will take to clean a tube.
Okay.
It takes hours, if not days, to shrink.
So if he came out to the OR with that in day 1, you could clean it the next morning, no problem.
Bingo.
Out a few minutes, cleaning it at the sink, and you'll be fine.
Absolutely.
You're not like on a timer.
No. And typically what we try to do is post-op day 1. If it's a nice clean scenario like that, we try to have the patient with a mirror in front of them doing it themselves. And if they can deambulate, we'll have them stand at the sink and do it.
Okay.
Just to increase their independence with it as fast as possible. And I think the big thing, especially with nursing handoffs, is the terminology, right? You see a trach tube in somebody, you're going to call them a trach patient.
Yeah.
We got to be a little careful with that because they're not actually a trach patient. They have a trach tube in their neck at the moment, but that's for healing purposes, but they're actually a total laryngectomy patient. where that's a permanent hole now. So if something moves around a little bit, it's not too scary. The other thing with that is rescue breathing. They cannot be intubated from above, because then you're literally intubating their esophagus. Oxygen has to be via neck only, even rescue breathing via the stoma in their neck. So just some considerations that way for
Eating.
you guys.
So do you wanna go over like a little bit of like,
Of which
for our new, like their diets?
Okay,
Just in
so
regarding new-
if it's for a laryngectomy patient, typically we will do their post-op video swallow day 7, day 5 if it's looking really good. And pretty much right out of the gate, we can start those people on general diets, unless there is a fistula. So that's the first thing we look for. We have them swallow some Omnipake. We look to make sure that the surgery is well healed. If we got any trace leaking into the tissues, they have to remain NPO until it's healed. If we don't spot a fistula in those first few swallows, we do protocol-wise go through purees and solids, but again, they can't aspirate anymore. So this is just to watch the flow through and make sure that their myotomies worked well, and just for our own kind of knowledge. But they are able to start eating post-op day 7 if it's a straightforward.
Do they feel that voice prosthesis?
Some of them, yeah, some of them do. Mostly with messing around with it, they feel pressure and not pain, especially once it's well healed. And these are people then we treat for the rest of their lives, because those voice prostheses need to be changed out a little bit like an oil change or tire rotation. So they follow up with us as outpatients.
Do they
on
do
that
it
end.
through the hole?
We go in and get it. The speech therapist too. So yeah, but it's easy enough with hemostats and dilators. So, but it is pretty specialized. So it's not just any speech pathologists that do this. I forgot to. So myself, Julie Coleman, and Michelle Brown are the 3 SLPs that do this here at Christ. And on this, which you guys will all be emailed, is our direct line numbers. I'm not sure why that is not coming back up. Any other questions for me, though? I think that was the last slide. Yeah. go for
So
it.
they always have no cuff. They're always balloonless, correct?
We prefer that, depending on what the OR is stocked with, yes.
But if they did have one with a balloon, it's always deflated.
Yes, unless there is a concern for ventilatory needs. So that's the question. I think one of the guys up here right now has some questionable ventilatory needs, so he might be in a cuffed trach.
Okay.
But again, it's same surgery, and every patient is so different. As you guys know, you know what I mean? So in an ideal world, they'll come out of the OR with the laryngectomy tube in place, right? Hip hip hooray. Even slightly less preferred is an uncuffed trach tube that we can then trade out in anywhere between 1 to 7 days, depending on the extension of the reconstruction.
Okay.
And least ideally is a cuffed trach tube that we can't touch.
Can you hook up the ventilator to the laryngectomy
You
tube?
cannot.
You cannot, so they'd have to be trached.
So correct. So
If they
let's
were
say
having, like,
you've got a
issues.
great patient who all of a sudden then right. What you guys would do is they always have a trach tube at the bedside for emergencies. What you guys do is take out the laryngectomy tube and just insert the trach tube right into the stoma. It's not like a decannulation hole. It's
Yeah.
so clear you can straight shoot it.
Okay.
Yeah, it's pretty easy. So those are for the emergency procedures. Yeah.
And
Is there-
that's why- I'm sorry. Go ahead.
Is there a certain size trach has to be at the bedside?
I think we say an 8.
Okay.
Because that's the same, an 8 Shiley is the same diameter as the 10 Larry tube that is there. So just to keep the stoma nice and well sized.
That's why, like, we had one that was out from OR that was intubated, so they had a regular trach. I mean, not intubated, they were on the vent,
Mm-hmm.
so they had a regular trach.
Yes.
And then when we wean him off the vent, then we'll just switch to the Larry tube.
When, are you talking about the person that's here now?
No, this was somebody else.
So yes,
A
with
while ago.
with ENT approval though, because the flap and the risk of the fistulas and everything else. So yeah, when ready, we'll come out and do that. Yeah.
Are there different size Larry tubes, or is it?
There are.
standard?
Yep, there are different sizes, like diameter wise, and there are different lengths. So, but we manage all of that with the patients. This is the one they'll get from the OR. This is the one you'll see, even not fenestrated, not with the holes.
You said that's a size 10.
This is a size 10, 55. 55 is the length. It goes 8, 9, 10, 12, 14, and then either 55 is the length or 36, which is a nice, more comfortable, shorter one.
Okay,
But this is the one you guys will see.
okay.
Can you illustrate, like, take it off the HME again, just
Sure.
while I have the camera on it?
So, nice silastic, pliable tube. The filter pops on, pops off, no turning, no locking. From a different angle.
And the button's there for, again,
So the button, when they're ready, they can push in on the button, redirect the air then through the fenestrations, through that little voice prosthesis, vibrating their esophageal segments. Yeah, it's cool. It's really neat that you can have cancer, take out your larynx, and still eat and talk more functionally than you could. That's why I love it. But
yeah.
And nothing's different if they need to be suctioned through it? Okay. Yeah, I can
they
do it.
tend to have really strong coughs, so suctioning needs are quite a bit less. What we teach them is how to pull off the filter and just cough to catch with the tissue. That's the hardest thing for people to learn, I think, is that they don't catch here anymore,
Yeah.
they catch here.
Mm-hmm.
But in some of them that are chronic trachs, that's already done, you know? So, yeah. Any other questions for me?
No, it's very interesting, thank you.
Ooh.
Like I said, when they're here, we're on them daily, so we're very available for questions, answers, teaching. That's, yeah,
Thank you.
we're happy to help. So, thanks everyone.
Can we keep any of these or no?
Yeah, that's fine. Can we leave them here
This
for
is
the
what I'm
next
talking-
one? Can we leave them here for
Yeah.
the next one though, so that Michelle can use that at
Excellent.
2:30?
Well done.
And then,
Thank you.
yeah, those are for your reference